Singh ma'am to address us and give us a briefing of what is ahead for us.
Thank you, Dr. Anurag and Dr. Avnish. Good morning, everyone. Today we are going to present the different topics related with chronic pain under the ultrasound and chronic pain part 2. In part 1, we have covered the role of ultrasound in chronic pain and current scenario, greater occipital neurolysis scanning and knee joint scanning and its interventions. Today we will cover shoulder joint scanning and its intervention, sacroiliac joint scanning and intervention, etc. So now I'm inviting today's program moderator, Dr. Avnish Khare. Welcome, Avnish Khare.
Thank you, ma'am. Thank you, everyone. So now, should I begin by introducing the first speaker?
Yes, yes.
Okay. So our first speaker is Dr. Nishad P K. He is MD from AIMS, DNB, Anesthesiology, MNAMS, PDCC in Pain Management from SGPGI, FIAPM. He is Director and Interventional Pain Physician, Cortex Spine and Pain Care. He is also in charge of Department of Pain Medicine in Aster MIMS. He is Program Head for Indian Academy of Pain Medicine Fellowship, and also he is Secretary of the Society for Study of Pain, Kerala chapter. So Dr. Nishad, I would request you to start sharing your screen.
Can you see my screen now? Yes, we can see.
Okay. So Dr. Nishad, the stage is all yours.
Okay. Thank you, Dr. Avnish, for the nice introduction. Good morning, all my seniors and dear friends. So today I will be talking about shoulder joint scanning and interventions. So the first part of the presentation, first 10 minutes, I will be talking about briefly about how we do a shoulder joint scanning, and the second part will be a small video presentation on the common pain intervention in the shoulder. So we know ultrasound is the best tool to do a dynamic examination of the shoulder joint in the OPD itself. So whenever we examine, first we will be taking history and examine the patient. I am not going to that details because we have only 10 minutes time to do all this scanning part. So whenever we examine the patient, we will have an idea what is the diagnosis. We want to confirm it by the shoulder scanning. But it is always better to do a protocol-based scanning. So Anurag sir, can you unmute all participants? So protocol-based scanning is always better so that we will not miss.
Dr. Nishad, you please unmute yourself. I have muted all.
Okay. Am I audible now?
Yes, yes, you are.
Okay. Okay, so whenever we are doing a shoulder joint scanning, we should do a protocol-based scanning so that we will not miss the things. So I'll be discussing like from anterior part, biceps tendon, then rotator cuff interval, then we'll assess the rotator cuff, all the 4 tendons of the rotator cuff, subscapularis, supraspinatus, infraspinatus, and teres minor, and the anterior medial structures like coracoid process and coracoacromial ligament, and followed by posterior structures like glenohumeral joint and spinoglenoid notch, and finally the superior part, that is acromioclavicular joint. I'll be discussing in this order. So regarding the patient position, always it is ideal to keep the patient in a revolving chair, not a revolving stool without a backrest, so that we can do a good dynamic examination of the shoulder, and the examiner is behind the patient, on the side of the patient, sitting or standing, and the scanning machine in front of the patient. That will be an ideal setting so that we can do a good dynamic examination of the shoulder. So in the anterior lateral aspect, the structures we are going to look is you can see this is biceps tendon, which is originating from the supraglenoid tubercle and coming through the joint, and it is entering into the bicipital groove through the rotator cuff interval. And just medial to the biceps tendon, this is subscapularis muscle, which is originating from the subscapular fossa and joining into is attaching into the lesser tubercle of the humerus. and lateral to that we have supraspinatus tendon. This originating from the supraspinous fossa and attaching to the anterior aspect of the greater tubercle. And medially, further medially, we have coracoid process from which biceps, short head of the biceps as well as the coracobrachialis muscle originate. And from the coracoid to the acromion, there is a ligament which is called coracoacromial ligament. Along with this acromion, this make the coracoacromial arch. Under the acromion, we have subacromial subdeltoid bursa and the impingement, which usually occurs in this coracoacromial arch. So we'll be seeing all this one by one. The first one will be the long head of biceps tendon. So the patient position is sitting with the you can flex the elbow at 90 degree and supination of the forearm and slight internal rotation. So you can locate the tendon in the bicipital groove, keep the probe in transverse axis, this short axis. So here you can see this is greater tubercle, this laterally, and medially we have lesser tubercle. In between there is a bright hyperechoic structure, round structure, that is the biceps tendon. Here our goal is to find out the position of the tendon itself. You have to confirm the position in the groove itself. Sometimes it might be subluxated or misplaced. And another thing is you have to find any fluid around the tendon. Is there any fluid around the tendon or the integrity of the tendon? For that, you have to scan the upper part. From the bicipital groove, you move upwards to see the intra-articular pulse of the biceps tendon. Here you can see medially it is subscapularis and laterally it is supraspinalis. In between, this is a rotator cuff interval where you can see the biceps tendon. And below also, you have to move below the probe. You should move below. You can see the myotendinous junction. That is, myotendinous junction is assessed at the level of the pectoralis tendon. You can see this bright structure. This is pectoralis tendon. You can see the short head as well as long head of the biceps tendon. After that, by keeping the tendon in the middle, you turn the probe 90 degree. So you can assess the longitudinal axis, long axis view of the biceps tendon. See, this fibrillar structure, this hyperechoic fibrillar structure is the biceps tendon. Assess for its integrity and look for any tendinopathies or any fluid around the tendon as well as any tear or any other issues. So here you can see this is the tendon. So the view, ultrasound view will be like this, hyperechoic fibrillar structure. So this is one pathology around the biceps tendon. You can see this is the biceps tendon surrounded by fluid. You can see the fluid, and even color Doppler it is showing hypervascularity. That shows that it is inflamed fluid. That is it is suggestive of tenosynovitis of the biceps tendon. After the biceps tendon, we look at the rotator cuff interval. Rotator cuff interval means a gap between the supraspinatus and the subscapularis. There is a gap through which the biceps tendon comes out. This is the hyperechoic biceps tendon, and you can see around it is actually kept in position by two slings of the ligaments. That is coracohumeral ligament. So here you can see clearly. So this is the coracohumeral ligament and superior glenohumeral ligament. Both of these keep the biceps tendon here. So while examining the rotator cuff interval, you should check the integrity of these ligaments, whether it is torn or whether it is misplaced the biceps tendon. If there is a subscapularis tear, the biceps tendon will move either under the subscapularis or above it. And if there is a torn CHL ligament, this will displace from this groove. So that we have to assess in this. After assessing biceps tendon, we'll ask the patient to move the forearm, externally rotate the forearm. So by keeping the elbow at the iliac crest, this is the position of the patient to assess the subscapularis muscle. Subscapularis is coming under the coracoid. By moving this externally rotating the forearm, it will come to under your probe. So this is a long axis view of the subscapularis muscle, which is attaching on the lesser tubercle. You can see medially that this is a coracoid process, and this point, you have to assess the integrity of the subscapularis muscle. Along with you can assess the subscapular recess and subcoracoid bursa. Here there is any fluid in the subcoracoid bursa. All these things you have to assess at this point. So this is a longitudinal long axis view of the subscapularis. The tendon which is coming and attaching here on the lesser tubercle. This is actually a wide muscle. So you have to sweep the probe up and down to see the entire width of the tendon. You should not miss the part of the tendon. Should sweep up and down to see this structure from above downwards, as well as you can do a cross-sectional view. This is just to make it vertical, so that we will get a cross-sectional view of the subscapularis. You can see it will look like some pathology, but this is a multi-pinnate muscle. The subscapularis is a multi-pinnate muscle, so it has several tendons. You can see 2-3 tendons, and so this is a normal view of the subscapularis tendon that you should understand. Here, this picture is showing a subscapularis tear. This is the full thickness tear. You can see part of the subscapularis is gone fully. This is the full hypoechoic area which is showing. This is the subscapularis full thickness tear, and here you can see the cross section is showing mid part of the subscapularis, some hypoechoic area. This part. So this is a partial tear of the subscapularis muscle. So when you say full thickness is if the full thickness or full width of the tendon is torn, we call it as full thickness, and it is a partial. It is some part of the it is resting, so we can call it as partial thickness tear. So this is more interested for us because we can treat it. For in case of full thickness tear, we have to repair it. So then, after assessing the subscapularis, you have to move the probe little bit more medially. You can assess the coracoid process as well as the coracobrachialis muscle, which is originating from the coracoid process. And here, two things you have to see: coracoid, subcoracoid bursa, any fluid or something is there, as well as you do a dynamic examination here. You do external rotation as well as internal rotation of the forearm, so that this subscapularis move in and out. So here you have to look for the anterior medial impingement in cases of shoulder, because between under the coracoid, the subscapular tendon will do an impingement that is called the anterior medial impingement. We have to assess the patient presents with the anterior medial shoulder pain. So we have to assess this by a dynamic examination. And after assessing the coracoid and this subcoracoid bursa, by keeping the probe on the coracoid process, you may make the lateral end of the probe towards the acromion, tilt the probe towards the acromion, so that you will see a hyperechoic structure between coracoid and acromion. That is a coracoacromial ligament. Along with acromion, this coracoacromial ligament form the coracoacromial arch, under which the common site of impingement syndrome happens. So after assessing the anterior medial aspects, we will be going to the supraspinatus tendon, and this is the most common tendon injured in the shoulder, either by tendinitis or by tear. It is the most common tendon, so we should be assessing this tendon in detail. So the most important part is this normally situated under the acromion. So by making this modified cross position, this is called modified cross position or hand in back pocket position. Here we are moving elbow posteriorly and internally rotating arm, and it is backward position. You can see this position. By keeping this, what happened is the supraspinatus will comes out of the acromion. Most of the beginners, in shoulder examination, the problem is to identify which is supraspinatus, which is subscapular. That is the most important issue, because everything looks like similar. So what we do is, first we find out the biceps tendon and keep the probe parallel to the biceps tendon. So you can see thick fibrillar structure of the biceps tendon easily, and from that you move lateral, posterior laterally. So that the first tendon which comes is the supraspinatus tendon. From the biceps, almost 2 centimeters, it is supraspinatus. So that way you can identify supraspinatus. So you may find out the biceps and make the same angulation, you move posteriorly. So this is the supraspinatus tendon. You can see the good hyperechoic fibrillar supraspinatus tendon which is coming under the acromion. This is acromion process. Under the acromion, the supraspinatus is coming and attaching on the greater tubercle. This is a greater tubercle. This is called the bird beak appearance of the supraspinatus. Here, one hypoechoic area is just above the supraspinatus and another hypoechoic area is just under the supraspinatus. You can see this above one is the subdeltoid subacromial bursa. This is a thin hypoechoic area which is normally it's like a very thin structure, and when it is inflamed you can see very well. So this is deltoid muscle, under that this is a subacromial bursa, and in between there is a hyperechoic thing, you can see that is a subdeltoid fat. So while injecting into subacromial deltoid bursa, you should not inject into this fat. And here supraspinatus, and you can see this black area. You should not think that this is some abnormality or it is some part of the bursa and all. While injecting, that is a common mistake. This is actually myotendinous tension of the supraspinatus. This is the muscular part of the supraspinatus tendon. And here, this hypoechoic area is the cartilage, the glenohumeral joint cartilage, this cartilage of the humeral head. So after assessing the longitudinal, you make it 90-degree cross-sectional view of the supraspinatus. This is again thick hyperechoic structure. You can see this upper part will be convex always. The normal tendon is convex, and medially you can see the biceps tendon. And here, this is a marking area. This is a conjoined tendon where infraspinatus continues. So supraspinatus is usually hyperechoic, and when the infraspinatus starts, you can see the slightly hypoechoic compared to that, so that you can identify it. So this is again the same picture. This is a cross-sectional view of the supraspinatus. From here onwards, it is actually infraspinatus. You can see it, and here is the conjoined tendon. So see this picture. This is a supraspinatus partial tear. So here, this is we are looking for this thing. That is hypoechoic area, but it is not crossing the full thickness of the tendon. So it is only this much part. So this is a partial thickness tear of the supraspinatus. Here you can see it is almost fully gone. You are seeing this bone, and then you are deltoid, and in between there is no. And it's a edge tear of this part is a supraspinatus, and this is the edge tear of the supraspinatus, full thickness tear. So you can here in this picture you can see it is a full thickness tear of the supraspinatus. And as well as the subacromial subdeltoid bursa is also you can assess while assessing the supraspinatus. You can see anteriorly this is a rotator cuff interval. Just above that you will see the subacromial subdeltoid bursa, and in longitudinal view here, just above the supraspinatus tendon, you can see the bursa. Here it is marked actually. So this is a subacromial and acromial subdeltoid bursa. So another, the beauty of the ultrasound in shoulder is the dynamic assessment. I told in the anterior aspect we will assess for anterior medial impingement. Similarly, you can assess the impingement and the subacromial arch, acromioclavicular, coracoacromial arch. Under the coracoacromial we can assess. So this is called impingement test. So usually we do impingement test when patient comes with lateral shoulder pain, and especially pain aggravate on abduction, that is painful arc. Then we can assess under ultrasound. So you keep the probe here, see the acromion and see the supraspinatus, and after that ask the patient to active abduction with the internal rotation of the forearm. So at this point you measure the distance between the greater tubercle and the acromion. So you can see if there is an impingement of subacromial subdeltoid bursa or the supraspinatus tendons here under the acromion. So that can be easily assessed by ultrasound. So after assessing the anterior medial aspect, we are going to the posterior aspect of the shoulder. Here the structures, you can see this is the spine of the scapula, which is becoming the acromion, and just above the spine of the scapula is supraspinous fossa, where the supraspinatus originates, and below that is the infraspinous fossa, infraspinatus originates, and below infraspinatus we have the teres minor. So these two tendons, that is infraspinatus and teres minor, is assessed in the posterior aspect. Under the infraspinatus, you can see the posterior aspect of the glenohumeral joint. That is a capsule of the glenohumeral joint, and just medial to the glenohumeral joint, this is spinoglenoid notch. So through which the suprascapular nerves comes to the infrascapular fossa. So this is the common area where the ganglion cyst happens, especially in cases of labral tear in shoulder. There will be associated ganglion cyst formation that is commonly here, and it causes compression of the suprascapular nerve. So you have to look, you should not miss this area while examining the shoulder. So here the next is the infraspinatus and teres minor. I already told it is below the spine of the scapula. We keep the probe perpendicular here. So you can see the thorax view of the infraspinatus muscle, as well as below that is the teres minor. So this is infraspinatus, and below that this is the spine of the scapula. Below that infraspinatus, and below that is teres minor. And you move the probe then little bit lateral, so that you can see the insertion of these two tendons, that is infraspinatus and teres minor, onto the greater posterior aspect of the greater tubercle. You can assess this, and you can assess the long axis view of the infraspinatus also by just keeping below the spine of the scapula, move it parallel to the spine of the scapula laterally. You can see the head of the humeral head, and above that is the infraspinatus tendon, which is joining to the greater tubercle. So under the infraspinatus, we have posteriorly we have the glenohumeral joint. So this is the humeral head. Round humeral head can be easily located, and medial to that we have the so this is the glenoid. So in between we have, this is the joints, shoulder joint, glenohumeral joint, and this hyperechoic structure, that is the labrum. So always you should be careful regarding this labrum. Whenever you do a shoulder joint intervention, should not injure this labrum. Okay, and you can see joint effusion or any collection here. All these things will be seen here. It will be fluid you can visualize here. And this is the area where spinoglenoid notch is there. So you should always look at this point. And while just turning the probe superior medially, you can see the artery pulsating here. That is suprascapular artery and suprascapular nerve can be visualized. And here it is the site of ganglion cyst. You should not miss this area. And after assessing the posterior aspect, we will be going to the superior part of the shoulder, that is acromioclavicular joint. So it is just to keep the probe on the superiormost aspect of the shoulder parallel to the clavicle. So you can see the medially it is clavicle, laterally it is acromion. In between the joint, you can see the capsule of the joint. Look for any irregularities on the bone surface or any correction of the joint. So it is a superficial joint. So by this, I have briefly covered the protocol-based shoulder joint examination. So it will be now we'll be moving on to the shoulder joint interventions. That is actually a short video presentation, and most of the things which I have discussed during examination also will be repeated here. So I think we'll continue with that video presentation. Thing is, shoulder joint intervention. It is advantage of the shoulder joint intervention. Say if you see the patient in the OPD, immediately you can put on the take a ultrasound and examine the patient, and we can do the intervention there itself in the OPD. That is advantage with the shoulder joint. So I'll be discussing about the common 6 procedures in the shoulder. One is a biceps tendon sheath injection, acromioclavicular joint procedures, and subacromial subtentorial bursa injection, and then PRP, which is a upcoming treatment for supraspinatus partial tear, and then glenohumeral joint injection, especially for adhesive capsulitis or glenohumeral joint arthritis. Then finally, I'll be discussing about the suprascapular nerve block or pulse radiofrequency ablation of the suprascapular nerve. These are the common intervention which is done in the shoulder. So most of the this procedure can be done in the OPD itself. That is the advantage with the ultrasound. So first I will be discussing about the biceps tendon. So we have already seen the anatomy of the biceps tendon. Usually the isolated bicipital tendinitis is very rare. You can see around 90% of the time when you see fluid around the tendon, look at the glenohumeral joint. It might be coming from the glenohumeral joint because it has an intra-articular force and the capsule of the joint is extending to the biceps tendon. So whenever there is a fluid in the glenohumeral joint, it will be coming into the biceps tendon. So if you see the fluid, you should assess the glenohumeral joint. So very rarely we have tenosynovitis, isolated tenosynovitis of the biceps tendon. At that point, we'll go for a biceptal tendon sheath injection. So here you can do a short axis examination, which I have already examined. Keep the probe in short axis, find out it, then assess the depth from skin to this area, and you can start that much distance below the probe. You can start from lateral to medial. That is easier. You can see under inline technique. You can see the entire length of the needle, and that is the in short axis. You do the procedure like that and enter inside the tendon. Only thing is you should be careful. There is a small artery there. So then after that you can do this tendon sheath injection in long axis also. So just to make the probe perpendicular and identify the tendon and sheath, and you can come from below upwards. It is easy to do from below upwards. And I prefer this long axis view for injection when I do a PRP injection for either chronic tendinosis or partial tear of the biceps tendon. Then this long axis view will be better, so that you can do a preparing of the tendon as well as injection. So this video is showing the short axis technique. It is coming from the you can see the probe. It is lateral to medial we are coming, and the needle is entering inside the tendon sheath. You should be careful. You should not inject into the tendon. Always should be careful. And another thing, you can see a small pulsating artery in the lateral aspect here at this point. So we should be careful. It is a branch of circumflex humeral artery, so we should not injure that artery. So it will be coming directly into the sheath and inject. You can see the fluid. Usually 1 to 2 ml of the solution is required for tenosynovitis. We injected 10 mg of panthenol along with the local anesthetic. 1 to 2 ml is enough to cover the biceps tendon. So this is the short axis view of the thing, and you can see the entire length of the needle. After this is technique where we are doing the same procedure under a long axis view. So you can see the biceps tendon and the needle is coming from below upwards. Here you can see the probe is kept longitudinal and we are going from below upwards, and it is entering inside the sheath and we are injecting. And this is more preferable for a PRP treatment of the biceps tendon. You can do a preparing of the tendon, like, and you can exactly identify where the tear is. That's the advantage of the longitudinal axis, long axis view. So by this, we'll cover the biceps tendon injection, and next will be acromioclavicular joint. So this is actually a diagnostic as well as therapeutic treatment. Whenever the patient comes with anterior superior aspect of the shoulder, and if you are having overhead abduction, he is having pain, and throw some abduction test. If the patient is having pain while holding on the opposite shoulder, then we have to think about acromioclavicular joint. Usually there will be tenderness on the joint. You can easily palpate the joint and patient have a point tenderness on the joint. Then you do an ultrasound examination of the joint for any fluid or so. See, this is the clavicle, this is acromion, again it is repetition. You can see the joint and you can see the capsule. And the thing is, since it is a very superficial joint, it is easy to inject out of plane technique. And in plane technique, what we have to do, we have to put a lot of gel on the lateral aspect. You can see this is gel, and you can enter from lateral to medial to make a long axis, or you can say in plane technique to the inside, to enter inside the acromioclavicular joint. But it is always I prefer out of plane technique for acromioclavicular joint. You can see the probe you are keeping cross section, and here it is only 0.5 centimeter. So you start 0.5 centimeter away from the probe and make it 45 degree of the needle, so that you will be directly entering inside the joint. You can see the needle tip inside the joint. So here you can see the needle tip inside the joint, then inject. Hardly you can inject 0.5 ml inside the acromioclavicular joint. That is a very small joint, so you should not over inject to cause injury. So just 0.5 ml is enough. So here you can see it is a long axis view. You put a lot of gel on the lateral aspect of the joint, and you can see the needle going parallel to the probe. So this is the in-plane technique. In-plane technique, and entering inside the capsule and then inject the same. Similarly, it is 0.5 ml solution you can inject. It is usually it is a common problem in old age individual patients. Next, we will be covering subacromial subdeltoid bursa injection. So we have already seen how to assess the supraspinatus, and just the superficial to the supraspinatus, you can see subdental subacromial bursa. If this in cases of bursity, you can inject either anteriorly, posteriorly, or on the lateral aspect. Everywhere it will be visible. This bursa will be visible anteriorly also. In this case, this is lateral aspect of the shoulder. You are keeping this is acromion. I already explained this because this hypoechoic area where we have to put the needle. Only thing is this acute angulation, the needle visibility will be difficult. So what you have to do is you have to measure this depth from the skin to this area. You measure the depth, then you start that much distance below. So if this is probe, you start little bit below so that your needle will be parallel. So if it is here the probe end, you start little bit below so that your needle will be parallel to the probe. So it will be easy to see the needle if you do like this. So most of the time we start just lateral because it will be difficult to see the needle. So just to measure that depth and start below that. Here you can see the needle is coming from lateral to medial. It is entering the subacromial bursa. So it is just a superficial tendon. Be careful, you should not inject inside the tendon. Most of the time this myotendinous junction might be missed as a subacromial bursa. You should be careful regarding that. And now the another technique is PRP injection, platelet plasma treatment for supraspinatus partial tear. Here, compared to other things, if you are in subacromial bursa, you can inject anywhere, but it is not like that. You should identify exactly where the tear is. For that, you make this position to see the entire supraspinatus modified class position and examine the tendon in detail, both longitudinal as well as cross-sectional view, and locate the tear where it is, whether it is the mid portion or the subarticular portion or the bursal surface. It will be different. Bursal surface tear, subarticular tear, different type of tears are there. You identify, or if already patient is having an MRI, you can see where exactly the tear is, and after that you can locate the tear in the ultrasound. So here cross-section we also you have to assess where it is, and then your needle should be exactly entering into the tear portion. So you can see here in this picture there is a partial tear in the here. This is a supraspinatus partial tear. You can see in the cross-section view also it is a good, actually a big tear, but it is partial tear. So the needle will be coming, will be entering inside the tendon. So here we are not injecting superficial to the tendon. Here we are entering inside the tendon and inside the tear. And the volume also should be calculated, because if it is a small tear, you should inject only 1 to 2 ml. You should not over inject also, that will further aggravate the tear. So usually 1 to 2 ml of PRP is enough. Less than 3 ml of PRP is enough to inject in the. So you can see the needle is, we are doing some peppering technique. That is puncturing multiple times and then injecting at the tear. So that is a technique for injecting PRP into the supraspinatus tendon. But the problem with this technique, we should not inject the local anesthetic here while doing PRP. So this is a painful procedure. So you can give a block or you can give some other analgesic to the patient. Glenohumeral joint injection in most, if it is thin patient, we can do with the same linear probe we can use like other structures, but for obese patient, we require a curvilinear probe. So here you can see this is the glenohumeral joint, this is the labrum. Here humeral head, you can see this is the cartilage. This black thing is the cartilage. So you will be entering either from lateral to medial or from medial to lateral. Both are okay. You can enter, but thing is the needle angulation will be little bit steep. So it will be difficult to visualize the needle. So it is better to use curvilinear probe if you are doing in a obese patient. But thin patient, it is okay with this linear probe. So here it is entering from lateral to medial. We can see it is, we are going from lateral to medial. This is the humeral head. This is the labrum, and here this is the joint space. You can see the glenoid here, labrum here, and this is the joint space. So we are entering, and this is infraspinatus and deltoid. You can see under the needle is coming and puncturing here. You can see the needle tip entering inside the joint. So only thing, while entering here, you can tilt the bevel of the needle downwards so that it will not injure. Needle tip is rotated so that it will not injure the labrum. And after that, then you can inject. Usually 6 to 8 ml of fluid is injected. You can inject for RDC capsulitis, you can inject local steroids, and or glenohumeral osteoarthritis, you can inject hyaluronidase, hyaluronic acid, or you can inject PRP. And this is medial to lateral technique. Here you can see entering from medial to lateral, and this is mainly centering it here. This is the head of the humerus, and here is a labrum. We are injecting here. We should not injure both this cartilage as well as we should not injure the labrum. That is the most important part while doing a glenohumeral joint injection. After that, we have suprascapular nerve block. You can it is usually done for adhesive capsulitis, chronic adhesive capsulitis, or glenohumeral osteoarthritis, or other shoulder pain, other chronic protective affair. All these things you can use for a suprascapular nerve block. Initially, you do a diagnostic block with a local anesthetic, and then later on you can do a pulse radiofrequency ablation. See, this is a probe is kept parallel to the spine of the scapula in the supraspinatus fossa. So you can see the trapezius, below that is supraspinatus, and here the supraspinatus fossa, you see there is a dip in the supraspinatus fossa, that is a suprascapular notch, and there is a artery pulsating suprascapular artery is visible, and there is a small ligament above that is artery, and below that is a nerve. Here you can see the medial to lateral approach is the commonly used for suprascapular nerve block. It's easy to do. So needle is starting from medially, and it is going laterally and entering here. Here also it is a deep structure, almost 4 to 5 centimeter deep. So you use a curvilinear probe, it will be better to see the needle. And
sorry, Dr. Nishad, perhaps time we need to take about the time.
It's over, sir. Over.
Yeah.
Last. Just finish. So this is we inject around 3 to 4 ml volume. That's all. So thank you. I have finished. Thanks a lot.
Thank you, Dr. Nishad, for such a nice talk. And I know it is really difficult to incorporate all these in 20 minutes, but you did a nice job. So should we move on to the next speaker? The next speaker is Dr. Pushpinder Singh, and he will be speaking on USG guided erector spinae block MIPSI. Introduction about him: he is a director of Veracity Pain Management and visiting consultant in pain medicine in Indian Spinal Injury Center. He has done DNB, then PDCC pain management from BHU. He has 5 publications with 3 in international journals, and he is also life member of ISA, ISSP, and ISPC. Dr. Pushpinder Singh, the stage is all yours.
Dr. Pushpinder, your time is 10 minutes.
Pushpinder sir, we cannot see your screen. Have you started sharing? Please unmute yourself. Please unmute yourself, Dr. Pushpinder.
You can hear me now, right?
Yes, we can hear you now. Yes.
You can't see my screen?
No, we cannot see your screen. Have you started sharing like last time? And no one else is sharing. Yes. Can you again retry sharing?
Screen is not visible.
Yeah, not visible. If you can cancel and retry sharing once.
Sorry?
You can close it and retry, like sharing.
Sharing now.
Okay, now retry.
Pause. It is showing your screen sharing is paused.
No, we cannot see the screen.
Showing your screen sharing is paused.
Also, we cannot hear you clearly. I think you are sitting a little far from the mic.
Okay.
Yeah.
It is just showing that my screen sharing has paused. I don't know why. Screen sharing has paused. That's the instruction is coming.
So, madam, what you suggest?
Dr. Pushpinder, you can resume screen sharing. If it is showing post, you can resume it. It will be coming there, that icon itself. Resume.
Here only?
That green button and share screen, there you can see there is a resume option will be there. Resume. If it is post, if it is showing post.
Resume share,
Yeah.
Can you see now?
I think it's not coming.
Clicking on that resume share.
You need to enter full screen.
Okay, I'll do that. Maybe that's it. Share. Can you see that?
Not
No,
coming.
the screen is blank.
Not visible, Dr. Pushpendra.
Clicking on that resume share, but then again it's not.
Dr. Avnish, till that time, there's a question. Probably Dr. Nishad can take it.
Yeah, okay. So we can
Yes, sir.
go for the Dr. Nishad. There is a question for you. Any resource you would recommend for USG shoulder and joint interventions, please, online or print?
Yeah, I will suggest one book, sir. I will put in that this thing chat itself. I will put the name of the book. Now itself, I will share it.
Okay, thank you, Dr. Nishad. So if anyone has any questions, please type in the chat box, and we can take questions towards the end and while
Hello.
Pushpinder is trying.
Hello, Avnish.
Yes, Dr. Thapa. Good morning, sir.
आपकी आवाज क्लियर नहीं है सर. थापा सर.
No, it got hung, I think.
Something to cover that time.
Yes,
sir.
Few inputs to make in ultrasound guided intervention. Hello.
Yes, please go on, sir.
Hello.
Yes.
बोलिए sir, बोलिए.
Thank you very much. In the ultrasound guided interventions, Dr. Nishad had spoken about various soft tissues. So that will be possible only with ultrasound and not with fluoroscopes. That is the one advantage of ultrasound guided interventions. There are many pain generators in the shoulder joint, like muscles, ligaments, joints. So those can be addressed by pain physicians only with ultrasound techniques. And with the help of fluoroscopes, you can only see the joints, and the soft tissues, they come as surrogate markers. And third thing about peculiarity of the shoulder joint is that the shoulder joint is a very bulky joint, and if you see the shoulder joint, it is held by the muscles and ligaments. It has a wide range of movements, so it has very scanty blood supply as compared to its shoulder muscle mass. So it is more prone to degeneration with slight trauma. And we are using various, there may not be problem with joint only, there may be problem with muscles, there may be ligaments. So sometimes we have to address the muscle only. Like in impingement syndrome, the supraspinatus muscle is process, sorry, not coracoid, acromin process. So
there is some problem in your voice. It is getting cut. Maybe connection issues.
the voice is not coming.
In between, it is getting interrupted, sir.
Now is it coming now?
Yes, it comes in between, but you can speak, sir.
Okay, thank you. So we have various intervention techniques like steroid injection, local anesthetic injections, pulse radio frequency of muscles, and these regeneration therapies nowadays, which are very popular. But the thing is that when you get analgesia with these techniques, we should advise physiotherapy also to the patient, because without physiotherapy, these techniques, they have short duration of action and then they come back to the square one position. So with gentle physiotherapy and with these analgesic techniques, then they will be able to get benefits. So repeat techniques, repeat injection may have to be done, and these injections are not panacea. It is not that one injection will serve all the purpose, but patient has to be advised also physiotherapy along with that. So now I can see the screen.
Yes, sir. Yes,
now we can see Dr. Pushpinder's screen. So, Dr. Pushpinder, now we can see. Please start your presentation. Thank you.
Okay, good morning, everyone. Sorry for the glitch. We will we're going to do in this session.
Dr. Pushpinder, sorry to interrupt. You will have to speak a little more loudly because we cannot hear you clearly.
So we will be doing a erector spinae ultrasound guided, and I'll cover this topic in brief headings. Dr. Ferrero was the one who in 2016 he described this block as an ultrasound guided interfacial block to manage severe thoracic neuropathy. And since then, next 2 or 3 years, it has been used in multiple clinical scenarios, including cervical, thoracic, abdominal, and pelvic conditions. Currently, the most common indications where erector spinal plane MIPSI has been used is basically to manage the pain of rib fractures, thoracic neuropathic pain, pulmonary malignancies, breast surgeries, then carotid endarterectomy to provide analgesia during this procedure, and also for post-operative analgesia for various surgical procedures, including the ventral hernia repair, medical prostatectomy, total hip arthroplasty, and even lift surgeries. So as we see, it has quite a wide indication these days. Coming to the anatomy, we know that the back muscles we can divide into the extrinsic and intrinsic group of muscles. And among the extrinsic muscles, we see on the left screen, we start from the superficial group, that's the trapezius, the latissimus dorsi, levator scapulae, and the rhomboids. And on the right side, we see the intermediate group, which comprises of mainly the serratus, posterior, superior, and inferior. This is basically the deeper muscles, which comprise of mainly the erector spinae. Now, as you can see in the slide, the erector spinae has basically it's a big muscle which is comprises of three fibers from three of these. This thing, that is the longissimus, the iliocostalis, and the spinalis, and it runs almost from like C2 to downward to almost the sacral region. So we can see the spinalis muscle, which is much medial than longissimus, and the iliocostalis. And they are seen in vertical distribution. And these are the intrinsic muscles, deeper to the extrinsic muscles, and which are closely related to the skeleton. And comprises of basically at the level, we can see multifidus, semispinalis, thoracic, and pedis. If you see these muscles in a horizontal distance, and then we can see in the transverse, we can see that the longissimus, the iliocostalis, and the interspinalis, they are just like superficial to the transverse process. And the nerve, the intercostal, the nerves. So when we see that there is the ventral and the dorsal branch, the dorsal ramus, the ventral rami, and the dorsal rami of the thoracic intercostal nerve. So the ventral that continues as the intercostal nerve, whereas the dorsal one divides into medial and lateral branches. The medial branch and the lateral branch. Now they are seen in this thing with the erector spinalis, this is in relation to the erector spinalis. So if we see that in this slide, then so this is the target. This is number 2. Number 1 is this was the target which was first defined by Dr. Agarwal when he described this block initially, but then gradually what was found was this was a suitable target deep to the erector spinal itself in relation to the transverse process. So over here, from here, what it can do is, because lower down, you see that this is the external intercostal muscle and then the internal intercostal membrane, and so this is the paravertebral space. So what we find is if you are depositing the medicine here deep to the erector spinal muscle, now this spreads to the paravertebral space, and the paravertebral space, it is in continuity with the vertebral space on the medial side and the intercostal space over here. So in a way, the medicine, if we are depositing it, by depositing the medicine over here, that is deep to the erector spinal muscle, so it reaches the dorsal rami also, and by reaching the paravertebral space, because it reaches the paravertebral space here, which is believed to be done through the costotransverse foramen here, which is the costotransverse foramen, or through the ligaments which are there, the intertransverse ligaments. So the medicine is believed to be spread through there, and it reaches the paravertebral space. So coming to the stenoanatomy, we start with by keeping the probe horizontal at mostly the 4-5 level, and then you can see the anatomy like this. In this figure, we can see this is the medial part and this is the lateral part, and this is the spinous process. This is the impression of the spinous process, the lamina, and then the transverse process. And these muscles here, mostly over, if you are scanning it over at the level above T5, mostly we can see 3 of these muscles. That is, mostly we would be able to see the trapezius and rhomboids and the erector spine. At D5 and above, the rhomboids basically tapers down, so we can't see we won't be able to see the rhomboids, because we can see the trapezius and then the erector spine. At the level below D5, mostly we can see these 2 muscles would be seen, the trapezius and the erector spine. And so this is the target. Our target is basically below the erector spine itself. But we do it in mostly we prefer doing it in a longitudinal plane, because at this level, at the level of the transverse process, what we do is we change the position to a vertical the position, and over here we should be able to see the impression of the transverse process like this. It should be more acute. If we are far lateral, then it would be more of a curved thing, because it might be over the rib, and then we can see it as a curve. Over here, if we can see this sharper this thing, we can count on the muscles from above. As I told you, we can see over D5 level, we should be able to see 3 of these muscles, trapezius, rhomboids, and at D5 and below, we will be able to see 2, that is trapezius and erector spinal muscles. So the target would be deeper to the erector spinal muscle, between the transverse process and the erector spinal muscle. You can see in this thing that marked by the arrow, we can see that it is deeper to the spinal muscle and just above the transverse process. So we just hit the to the in-plane approach. We go down, holding the probe in vertical position, and hit on the transverse process. The vertical height is mostly found between 3 to 4 centimeters. We hit on the transverse process and deposit this local anesthetic beneath the rectus.
Dr. Anurag, please mute all.
Okay.
Sorry for interruption. Dr. Anurag, please mute all.
Okay. So local anesthetic is deposited just deeper to the erector spinal muscle, and just basically between the erector spinal muscle and the transverse. And we can then see the spread at the
Pushpinder sir,
Dr. Pushpinder, unmute करिए अपने को. Dr. Pushpinder.
I have done that. And you can can hear my voice, right?
Yes, we can hear you.
I'm just trying to play this video now. So as I told you, mostly you can take any of these positions. You can do it in sitting position or lateral position, anesthetized positions, or even in prone position. As you can see, we have marked the spinous process and almost 3 centimeters lateral to that. So we just start basically scanning from the spinous process. If you can see in this video, okay. So, and after over the transverse process, we change the position to vertical orientation. We change the orientation of the core. And you can see here, like this is basically the impression of the transverse process. And so, and over these, we can see these muscles. So if we are doing it at above the level, we should be able to see 3 of these muscles: the trapezius, the rhomboids, and the erector spinae. This is how we are inserting the needle. So it is in plane approach.
Dr. Pushpinder, your
I'm
voice
just
is
trying to
not
move
coming.
the next slide here.
Okay.
Yes. So as we can see, so we should be able to see the spread of the local anesthetic beneath the erector spinal muscle. So in this thing to the transverse process, and we can actually trace it above, capillary as well as caudal to that. Mostly, we would deposit a volume almost as high as almost 20 ml, because if we would like so that more the local they can be spread both capillary as well as caudal to that. So we would give this much of volume, almost 20-30 ml volume if it is a single shot. Whereas if we are giving a continuous block, we can do that by using a 2-piece needle, and through that we can insert a epidural catheter into it and can connect it to a pump, and then it can go almost at 4 to 5 ml per hour. So mostly in most of the indications, like for managing the pains of the rib fractures, or even many other indications, we would actually use it for on a continuous listing, where we can actually put these catheters and retain these catheters for almost 5 to 7 days, and get the local anesthetic going through. This would be mostly the area of hyperesthesia till almost anteriorly till the midclavicular line, we can see. So the vertical as well as the horizontal spread is almost seen till the midclavicular line. This diagram just shows in a cadaveric this thing and the dye, and we can see that the dye actually moves till we see that even the external intercostal muscle, deep to the external intercostal muscles also, the spread of dye can be seen. So in the vertical spread, we can see if we are doing it at a level almost D7 at D6 or D7, then the sensory loss is seen till almost from C5 to L2. Whereas for like in carotid endarterectomy, we do it at D2-3 level because we want a level higher up, and then we can achieve a level from almost C3 to T5. So this study was done by Swashman et al. And basically injecting the local anesthetic along with gadolinium dye, and the MRI images were taken, where it was found that the spread of the dye, I'm not able to look at this slide.
Pushpinder sir,
I'm just finding it difficult to move to the next slide.
yeah, just where
now it's there. Yeah. So sorry. So we can see that the dye could be seen in the foramens as well as in the epidural space. You can see the dye in the epidural space as well as in the full foramen. And over here also we can see the dye. So it was said that the mechanism of action of erectospinal block is likely due to the transforaminal and epidural spread. And so which could be a advantage using if you are using intercostal block. So since here, so the dye could actually reach the transforaminal and epithelial space. So this was one of the reasons why how its action is there. And comparing this to the another block, which is the retrolaminal block, comparing the erectospinal plane block. So the dye spread in a retrolaminal block and the erectospinal plane block. So the retrolaminal block is mostly done like medial to that. It is at the level of lamina. So basically, it is done here. So this is the target. Whereas in a erectospinal plane block, this is the target is between the erectospinal muscles and the transverse process. In a retrolaminal block, it is at the level of the lamina. The muscle at the level of the lamina. So and it was found that in a retrolaminar block, because this is the center, so what it was found was the dye restricted more towards the center. It was epidural spread and the distinct spread, but then the spread in the intercostal towards the intercostal spaces was very less. Whereas in a erectospinal block, the spread was not only in the epidural and this thing as we saw in the MRI study, but then it was also more lateral spread, which was found. So this was the advantage with this. So it was said that both erectospinal block and the retrolaminal block, they produce epidural and neuroforaminal spread, as we can see here. But with the erectospinal block, we can see more of an intercostal spread, which was absent with the retrolaminal block. So the advantage what we achieve with the erectospinal block is that the dye spread is not only it's not only medial towards the epidural space, but it's also more lateral also towards the intercostal space. So we get sort of a like, so it's like what the spread is with the paravertebral block. And since it is more of a superficial thing, we need not to go that much deeper also. So that is the advantage, and so therefore there is less risk of pneumothorax compared to the intercostal block, where we are working quite near to the pleura. And since we are doing mostly the intercostal block, we had to use mostly out of plane approach. So the risk of pneumothorax was quite high, and it was a deeper block. The risk of pneumothorax was there, which is quite less seen with the erectospinal block. And there is also a low incidence of direct epidural injection. Reason being because the orientation of the needle is mostly from upwards, downwards, or downwards, upwards. It is not from the sideways. So the chances of epidural injection is also less. It can be easily given in the emergency department, and there has been a study where it has been used to manage acute low back pain. So there has been which was a case series where patients coming to the acute low back pain, this block was done, and patients were sent off right from the emergency, except their pain could be managed with this block. And it is also relatively more safe in patients on anticoagulant, since there are, although not advised, but then still, if you're doing it in emergency basis also, then even if a patient is on anticoagulants, it is relatively more safe than the blocks like the intercostal block.
Thank you, Dr. Pushpinder, for such a nice talk. Now, moving on to the next speaker, I would like to introduce Dr. Varun Singla. He will be speaking on ultrasound-guided sacroiliac joint MIPSI. And he is a dynamic pain physician from Chandigarh, and he has done MD from PGI and PDCC from SGPGI Lucknow. He started working in Safdarjung Hospital, Delhi, and he is associated to various private and corporate hospitals of Gurgaon. And presently he is working as consultant at Revive Pain Spine and assistant professor at MMU Ambala. Dr. Varun Singla, your time limit is 20 minutes and the stage is all yours.
Thank you, Dr. Avnish. Thank you for the kind introduction. So I am Dr. Varun Singla, and I'll be talking about ultrasound-guided sacral joint injections or the interventions. So I'll try to keep it simple because this initiative is for the young pain physicians and anesthesiologists who want to learn pain medicine. So coming to the topic, so first of all, what is sacroiliac joint pain? Sacroiliac joint pain patients usually present to us with buttock pain, low back pain, and relating to thigh or anteriorly. So they usually pinpoint to the PSIS or sacroiliac joint, and when you do the provocative test, you find it positive, like Yeoman, Ganslen's, or Petrick or Faber test you can do. So they will come to positive, but the problem is that when you do all these tests and you take the history, you have a suggestion that this is a sacroiliac joint pain, but this is not the diagnosis. So the gold standard for diagnosis is injecting local anesthetic into the joint and looking for the response. If this is positive, then you show that this is a pain generator, is a sacroiliac joint. So that is why it is very important to understand and know the injections or the interventions for sacroiliac joint, so that you can diagnose the pathology and also you can treat that. So there are many ways we do it. We can use fluoroscopy, which is a C-arm or the X-ray machine in the OT, or we can use ultrasound, or we can use CT or MRI. CT, MRI are little cumbersome techniques, and you need a separate CT console and MRI console for that, and these are expensive too. So usually conventionally we use fluoroscopy for sacroiliac joint interventions. There are some advantages and some disadvantages of the fluoroscopy, and recently we have started shifting to the ultrasound, and this is the new technique that we are using, although it has been like a decade since we have been using it, but since now also many of us are not using that. Let's start using it and let's understand how we do the ultrasound guided interventions, specifically talking about sacroiliac joint intervention. So in this figure, you can see that there is one sacrum, you can see a bony shadow, and one ilium, you can see that is bony shadow, and in between, when there is no bony shadow, there is a joint, sacroiliac joint. So first of all, let's come to the anatomy so that we can understand the ultrasound anatomy after that. So the basic anatomy of sacroiliac joint is that it is the joint between the sacrum on the medial side and the ilium on the lateral side. So this is a diarthrodial joint. This is a big joint in the spine. You can see that on the lateral, this is the lateral view. Keep this in mind because this is important while taking the lateral view picture on the X-ray in the fluoroscopy. Looking from the side, this is the S-shaped joint. So now you can see that from the posterior side, this is the ilium, this is sacrum, and in between this is the sacroiliac joint. The ultrasound that we usually use is the curvilinear probe for this, and we keep it in a transverse view. And I try to do it in plane technique rather than out of plane technique so that we can see the needle clearly. So here you can see the spinous process in between, in the midline. Now he's moving the probe a little laterally. Now moving the probe laterally, you will see the lateral crest of the sacrum. And then you will see the superior iliac spine or the posterior superior iliac spine. Then a little bit of maneuvering capsular and caudal and a little bit of tilting, you will be able to see the proper sacroiliac joint. And also when you go down, you will be able to appreciate the sacral foramina S1, S2. So we'll be coming to it. Don't worry. So how I do it? So I do it in a two-way. I do two techniques. I call it for simplification up-down technique and the down-up technique. When we are moving from the up-down, like we start from the L5 spinous process and then we go a little laterally to see the PSIS or the posterior iliac spine, and then we go down. So this is called as up-down technique. And when in the down-up technique, we start from the sacral hiatus, and then we go up and then a little laterally. So we are going up in this. So we call it down-up technique. First of all, up-down technique. This is the L5 spinous process. In the image, you can see that. Moving a little laterally, you'll be able to appreciate this PSIS. Probably I can't move my cursor. You can see my cursor. So this is the PSIS and this is the lateral crest of the sacrum. In between, this is the sacroiliac joint. So coming a little down, you will be able to appreciate the sacral foramina here. Maybe I can show this again. Maybe I can show this. Okay, so we'll go to the caudal, the down-up technique. This is the sacral cornuas. We're going a little up. This is the midline sacrum. We're going up. And now we need to move a little laterally to appreciate the sacroiliac joint. This is the lateral crest of the sacrum. This is sacrum. And this thing we see, this is the ilium, and in between this will be the sacroiliac joint. So here we can see the sacral foramina. Here will be the sacral foramina. When you move capsular and caudal, you will be able to appreciate it better, the sacral foraminas. So here I am trying to show the sacral foramina in this image. So you can do it at the S1 foramina or you can do it at the S2 foramina. So this is the first image in the S1 foramina. So this is the S1 foramen. When you move from the midline to the lateral side, first of all, you will appreciate the sacral foramen, and then you will come to the sacroiliac joint. So the next shadow is of the sacroiliac joint. And in this lower figure, you can see this is the medial sacrum. This is the lateral crest sacrum. Then you appreciate the S2 foramina, S2 sacral foramina. Then you move a little lateral, then you will see the sacroiliac joint. So this is how we do it. I try to do it at the level of S2 foramina because it is a little easier. The depth is a little less as compared to the S1 foramen. And one thing very important here is that when you are doing it a little superiorly, when you're doing it at a upper level, superior level, the sacrum, the ilium is little tilted towards the medial side. So you need to move your needle medial to lateral. While if you're doing a little inferior side, like if you're doing at S2 foramen, it will be vertical. So you can go directly. A little bit medial to lateral will be required, but not that much, right? So this here you can see that in this figure, this is at the S1 foramen. Here is the sacroiliac joint, and this is the S1 foramen. So you need to go a little medial to lateral here in this, while in the S2 foramen it is quite easy to do it. A little, not that much angulation is needed. It is a little less depth is required is also there. So better to go for S2 foramen. One more thing, the synovial joint is in the inferior portion of the sacroiliac joint rather than in the superior portion. In the superior portion, you will see more of syndesmosis. So, and interosseous ligament is also there on the superior side. So, better to go in the inferior part. So, a little video to show how I do it. So, these are the requirements, the equipments that we use. This is the curvilinear probe. We can use a linear probe also in thin patients if it is not that deep. Otherwise, you can use curvilinear probe. So patient is lying prone. We can mark it, the sacral hiatus, sacral corner. We can mark PSIS in the cross mass, and the dot is the probable intervention we will be doing. So this is the down up technique that I am showing. So we move the probe in the transverse view from the downside in the midline, and then we move laterally where we propose to do the intervention. So here you can see the sacral hiatus, and then you can see the sacral cornuas, and moving up you in the midline, midline sacrum. So this is the midline sacrum, and you have started appreciating the lateral crest of the sacrum now. So a little bit of movement upside, you will start seeing the ilium, and when you start seeing the ilium, then you are in the inferior portion of the sacroiliac joint. So this is the sacroiliac joint. This is the lateral crest of the sacrum. This is the ilium. So this is the sacroiliac joint. If you move up, you can see the S2 foramen and S1 foramen. I am sorry, I am not able to show in this video. This is how we go in plane. From medial to lateral, the needle position is medial to lateral. So here the needle is coming. Not that good a video, but probably if you are able to appreciate the needle. So this is the lateral crest of sacrum. This is the ilium, and this is the sacroiliac joint. So here we are entering from the medial to the lateral side. So what I do is I usually check in the fluoroscopy after I have placed the needle inside the joint via ultrasound. So after that we can give the contrast injection and see if we are inside the joint or we are giving it periodically. Probably we might be giving periodically also. So better to use fluoroscopy along with it. Although there are critics who say that there's no use when you are doing ultrasound, but I use fluoroscopy along with it. So a little bit of tips for fluoro-guided sacral joint intervention. If the organizers permit, I would like to share a few tips for fluoro-guided also, because we are doing more of fluoro-guided and we are shifting to SIJ. So I thought
please go on. You have time.
So, thank you, sir. So this in the first figure you can see this. Usually, how we do the fluoroscope guided, we use a little cephaloid, 10 to 15 degree cephaloid position of the fluoroscope tunnel, and a little bit of contralateral oblique from 10 to 15 degree. So that this is why do we do this contralateral obliques to place the anterior and posterior sacroiliac joint lines in line. So that is why we do it. So we can see the single joint, and we can do it easily. So in this first figure, you can see that this is the medial lip of the joint, medial joint line. So we use a curved needle and we try to hit the medial side of the joint line, and then we tilt the curve of the needle a little laterally, and we enter the joint, and then we can move it a little cephaloid, and then we can inject the drug. So that is the usual technique that we do. This is the AP technique or the PA technique, in which we need not go for any obliquity or cephaloid position of the fluoroscope. We can do it directly. It is very fast. So the important thing in this is that you will see two lines here, two joint lines here. One is the medial joint line, one is the lateral joint line. So always remember, this is the golden point, that medial joint line is where you need to go. This is the posterior one, while the lateral joint line is the anterior sacroiliac joint. So go for the medial joint line in the inferior part, just like normally you do it. Little cephaloid position of the needle is advisable. Try to go little towards the S2 foramen. And in this figure down, you can see this is the contralateral oblique technique. You can see a single joint with two joint lines, and here you can see four joint lines with two joints. The middle one is the posterior joint, where we do the intervention, while the lateral one is the anterior sacroiliac joint line. People, when it is reported that if you are not able to intervene in the medial joint line, that is the posterior one, you might go into the lateral joint line also. You can try the lateral joint line also, and you might be successful for that also. So you can do that also. This is a very good technique I use in difficult sacroiliac joint interventions when I don't want to take chances. So what I do is, this is the double needle technique. We use two needles in that. First of all, the usual technique of the contralateral oblique, and then we go into the joint. We place the needle inside. But the problem while injecting contrast is, if it is not inside the joint, there will be a patch on the film. You will not be able to direct it again, or you will not be able to use another needle and go inside the joint, because you will not see anything on the picture. So you place the first needle, and you tilt the X-ray machine a little oblique, lateral and medial. You do a dynamic fluoroscopy, and you try to see if the needle tip remains inside the joint or it is moving along at the bone. If the needle tip is inside the joint when you are moving the fluoroscope from the lateral to medial obliquely, then it is probably you are at the right space. If it is coming to the bone, like in this second figure, you can see, first of all, this first figure, we have placed the needle inside the joint, but when we did the different angle position of the fluoroscope, we found that the needle was rather on the bone, not in the joint. So keep that needle there only, don't take it out. Use another needle at that angle and inject and place the needle inside the joint. Then you can give contrast. You have two needles inside. Now you try to give contrast from the first needle, and then you try to give contrast to the second needle. Either one of it can be inside the joint. So here you can see that the second needle is inside the joint, while the first needle is showing the contrast a little medially, probably a vascular uptake. So this is a very good technique. People have done in the superior sacroiliac joint also. I haven't done this, but they have reported that they start from the L5, little below the L5 spinous process at the L5 S1 disc, and then they go at the 45-degree angle laterally towards the superior sacroiliac joint, and then they enter the sacroiliac joint, and then they inject. So probably because in the superior portion the ileum is a little medially, But the sacrum is a little like this, so you go, or you have to go quite middle to lateral position. So that's why they have started from the L5S1 desk. So I would like to tell that always, usually we don't do this, but always try to do a lateral fluoroscopy, take a lateral view also when you are doing sacral intervention, and try to keep the needle a little above the S2 foramen. Try to keep the needle a little bit above the S2 foramen in the lateral view, and when you do arthrogram, when you inject the contrast, you will be able to see the sacroiliac joint. You will be see the arthrogram of the sacroiliac joint quite visibly, and you're quite sure that it is inside. Although in the AP technique or the oblique technique also, there is contrast moving in the joint, but little technique is you will be quite sure with that.
Dr. Varun, we are running just a bit short of time, so
I'll be finishing.
Yeah. Okay.
So a little bit about the benefits and the drawbacks of ultrasound and fluoroscopy. So with ultrasound, you can it is portable and it is easy to use, and it is greatly accessible. There is no ionizing radiation. These are simple. These are the usual advantages that we have. But there are some disadvantages also in when we are using it, because we won't be able to inject contrast and see the arthrogram in ultrasound. So we can do it via X-ray fluoroscope, but not with ultrasound. And the accuracy with sacroiliac joint in the sacroiliac joint is a little less as compared to fluoroscopy. It is around 87-88%, while with the fluoroscope it is 98 to 99%. So when you're doing diagnostic injections, particularly, try to go for fluoroscopy, because you want to be sure and you want to pick all the patients. You don't want to miss them. While if you're doing those therapeutic, you can go for ultrasound injections. In this, I found this very interesting study in which they have used color Doppler for ultrasound intervention. Like we are discussing that in fluoroscopy, we won't be able to give contrast. We won't be able to verify that is inside the is it intra-articular or not. So they have what they have done is they have used color Doppler. When they are injecting the drug inside the joint, they have placed the needle. Now they are injecting the drug. They start the color Doppler on the ultrasound, and while giving the drug, if there is flow, there will be reverberations in the color Doppler, and you will see that it is not moving. The reverberations are not moving outside, but they are inside the joint. Then you are quite sure that we are intra-articular in ultrasound. So, lastly, some points to remember. So, try to target the inferior caudal joint space. For the young pain physicians who are starting. Needle direction is from the medial to lateral, because the orientation of the sacral joint is like this. The clinical efficacy, this is controversial, whether to give intra-articular or peri-articular. With ultrasound, probably you might give peri-articular also. You might not be able to go intra-articular, but the clinical efficacy has been shown to be same with peri-articular or intra-articular. So don't worry if you have given peri-articular also, or it might be giving good results with that also. So needle placement accuracy, better with fluoroscope than ultrasound. So for diagnostic injections, better to verify with fluoroscope rather than solely going for with ultrasound. The learning curve is there. You see, the COVID era is going on, and we are using masks now. Now we are used to the masks. Earlier, when we started putting on masks, it was very difficult. We felt breathless. Now it is easy. And rather that has now when I go out, if mask is not on, I feel something is missing. Same with the ultrasound. So when you start with it, it might be difficult, but when you are used to it, you will miss ultrasound. Thank you. Any questions you can please ask.
Thank you, Dr. Varun. The questions we will be taking up towards the end, so I request everyone to please type their questions in the chat box. Moving on to the next talk, we have Dr. Akanksha Agarwal. She will be speaking on USG guided lateral femoral cutaneous nerve MIPC. To introduce her, she is DNB PDCC in pain from SGPGI Lucknow. She completed her MD from Maulana Azad Medical College, and presently she is working as senior resident in SGPGI in the Department of Anesthesiology. Dr. Akanksha, your time limit is 10 minutes and the stage is all yours.
Thank you, sir, for warm introduction, and I thank all my mentors for giving me this opportunity. Is my screen visible to all?
Yes, it.
Yes.
Okay. Topic given to me is lateral femoral cutaneous nerve myopathy, and I'm going to go with quickly. So I'm going to cover my presentation in these subheadings, and starting with the introduction. Now, when you say lateral femoral cutaneous nerve, it is a pure sensory nerve and it supplies the skin of the anterolateral aspect of thigh. And there is a condition where this nerve is involved. It is called myalgia paresthetica, which presents as paresthesias, numbness, and pain over the upper lateral thigh. As we know that there are certain predisposing factors to it, which include obesity, pregnancy, or there may be trauma, there may be an abnormal anatomy, or the people may be wearing tight jeans or belt, or certain iatrogenic procedures like anterior approach arthroplasty and iliac bone grafting. So these patients, there is an indication of LFCN whenever there is failure of the conservative management, or we have to pose the patient for the therapeutic neurolysis. We need a successful diagnostic block. So I want to explain the anatomy of LFCN. Now, anatomy is here important because it is a very small nerve. The cross-sectional area is less than 1 mm square. So we need to understand the anatomy, where it starts. It starts from the L2 and L3 sensory nerve roots. It descends laterally over the surface of psoas muscle, and at the lateral border of psoas muscle, it runs downwards and obliquely over the surface of iliacus muscle. Here, then it goes beneath the inguinal ligament, running over the surface of sartorius muscle. It then divides into the two branches. So this is the area which lies between the sartorius muscle and the tensor fascia lata. This is the space where we need to identify our muscle. Now, this nerve, it is important to know the certain variations, because most of the patients, what I have previously described was the usual course, but there are certain patients, about 30% of them will have variations, and that will result in a block failure. For example, the nerve may divide before the inguinal ligament, or the distance from the ASIS may be ranging from 0.6 to 7 centimeters, or it may be even lateral to ASIS, or the nerve may even pass through the sartorius muscle. So these variations have to be kept in mind, because unless we know them, we are going to miss this nerve. Now, starting with the scanning technique, it is a notorious nerve, which is a small nerve. So we need to be very particular with the scanning technique. The position of the patient has to be supine. The probe, since it is a small nerve, higher frequency probes of more than 12 megahertz is required, and it is a linear probe. The depth of the screen, the depth has to be adjusted to 1 to 2 centimeters, because it is a superficial nerve. And I'm not saying it is a subcutaneous nerve, but it is a subfacial nerve. So it is a superficial nerve. And the anatomical landmark I need to identify is ASIS. Now, where I have to place my probe, it is at least 3 finger breadths below the ASIS. As I see in this diagram, I have placed my probe below the ASIS, approximately 3 finger breadths below. This is a technique which has been described by Nielsen et al. In 2018. Now, coming to sonoanatomy, it is important that I should know where should I start my scanning. So the ideal site to start scanning is in between the sartorius muscle and the tensor fascia lata. And from there, I go proximally to the ASIS level. So it is important that I start distally and I proceed proximally. Now, when I place my probe, I have to localize for this small nerve. Therefore, it is important to collaborate my anatomy with the sonoanatomy. This is a panoramic anatomical view of the various muscles from medial to lateral, and this is the ultrasound view of the same. As I start from the medial 1/3, I am able to visualize the femoral artery, femoral nerve, iliacus muscle, and above lies the fascia iliaca. As I go further laterally, there is iliacus muscle and sartorius muscle. And here is my target. Here is the sartorius muscle and tensor fasciae lata. And in between there is a groove, there is a tunnel where lies the lateral femoral cutaneous nerve. Now, when I localize my nerve, this is seen as a hyperechoic nerve, which is lying within the hypoechoic fat-filled tunnel between the tensor fasciae lata laterally and sartorius muscle medially. And here lies the fascia lata, which is above the nerve. So when I start with the needle insertion, either out of plane or in plane technique is suitable, but in plane technique is preferred because I am able to visualize my needle. Now, when I inject my local anesthetic, what should be the optimal tip location? It should be just underneath the fascia lata. And when I give my drug, volumes of approximately 5 to 10 ml is sufficient, because this amount is going to cover the proximal branches as well. And my goal will be to raise the fascia lata at the time of local anesthetic injection and fill the tunnel. Like in this figure, I can see my needle, which is the needle tip, which is lying just below the fascia lata. And in the next figure, I can see the local anesthetic is covering the nerve. That is, it is covering the whole tunnel between the sartorius muscle and the tensor fasciae lata. Now, there are certain clinical pearls. These are very important for this particular nerve because it is easy to miss nerve. The key to success is first locate it distally in the space and then trace it proximally towards the ASIS. Also, we need to apply a very gentle transducer pressure, because once if we apply more pressure, this is going to obscure the nerve and nerve is going to get collapsed. Also, in thin individuals, apply copious amounts of gel so that there is maximum acoustic coupling. Now, once the procedure is done, how I am going to evaluate? The patient himself will say there is a relief of pain in the area of distribution, and there will be a cutaneous anesthesia between the ASIS and the lateral knee joint line. And once my diagnostic procedure is done and it is positive, what is going to be my next step? Now, there are various options available. There may be surgical options or there may be pulse radiofrequency ablation. The neurolysis for meralgia peristhetica can be done by surgical decompression, where the surrounding tissue is neuralized, and it has been seen that it provides adequate pain relief with minimal complications. Then there are the neuroablative procedures for LFCN, and one of them is the pulse radiofrequency neuromodulation. There has been not much studies, but one retrospective study and 3 case studies regarding this, and it has shown that it provides good pain relief, and that is also long lasting. Since it is a sensory nerve, we prefer pulse radiofrequency. We use temperatures 42 degrees Celsius for 2 minutes. And it has been shown with minimal complications and has been useful for the patients of meralgia peristhetica refractory to conservative medical treatment. Then these are other studies, though there are various surgical procedures like neurolysis, neurectomy, transposition, but there is an insufficient evidence to recommend one method over the other. Also, there has been many case series regarding the pulse radiofrequency, and one of them shows if we extend the duration of pulse radiofrequency, that has shown the long-lasting benefit. These are the references of my presentation, and thank you, everybody. Thank you. Thank you, sir.
Thank you, Dr. Akanksha. It was a nice talk, and you summarized it very well. And with permission of Dr. Anurag sir and Dr. Sarita ma'am, can we take the questions now from the participants?
Yes, yes.
Okay, so I will go with the first question. It is for Dr. Nishad. How much volume to be given in adhesive capsulitis for hydrodissection? So, Dr. Nishad, please unmute.
Hello. How much volume we are injecting? Actually, it is 20 to 50 ml volume we can inject.
Please mute yourself. I would request all other speakers to mute.
Hello?
Yes.
20 to 50 ml volume we can inject. Actually, up to 50 ml volume we can inject for hydrodissection. Actually, we have to, along with if you do a steroid injection, that will be better. Symptomatically, it will be better if the inflammation part will be taken care of by the steroid, and the volume will distend the capsule. That will be beneficial.
Anyone else would like to add on this? Okay. So moving on to the next question, Dr. Pushpinder, question is for you. In your opinion, which is better, erector spinae plane or paravertebral block in respect to analgesic efficacy? From Dr. Rajiv Gautam. Dr. Pushpinder. Please unmute yourself, Dr. Pushpinder.
Can you hear me now?
Yes, we can hear you.
Can you just repeat the question, please?
Yeah, the question is for you. Dr. Rajiv Gautam is asking, in your opinion, which is better, ESP or PVB, paravertebral block, in respect to analgesic efficacy?
See, in respect to analgesic efficacy, I would say that the erector spinae block provides almost as much efficacy as the paraspinal block does. The efficacy is almost as much as because as we discussed, if you are giving a erector spinae block, the effect is almost the same as is achieved by the paraspinal, because the spread of the medicine is because even if you are giving in a erector spinae, this thing we put to the erector spinae, the spread of the local anesthetic is almost as good as what we get in a paravertebral this thing. So clinically also what we have seen is the effect is almost comparative to what we do is a paravertebral or intercostal block. Because if you are doing a paravertebral block actually with the ultrasound, it is more of an intercostal nerve block than a paravertebral block. So what I mean to say is the effect is almost as good as a intercostal nerve block. We have done it, and I've used a continuous block to manage these rib fracture patients, and the effect is quite good. And with its and with its advantages that since it is much more superficial, easy to give, even if I would say the chances of bleeding are quite less, and as well as the other complications like pneumothorax and the epidural injection, I would definitely think that erector spinae block is much better and much easier to perform than doing an intercostal or paravertebral.
Please mute all parts. Okay. So anyone else would like to add on this based on experience, erector spinae or paravertebral?
Yeah, Avnish. Hi, this is Dr. Chetna. Hi, Dr. Avnish.
Yes, Dr. Chetna, please.
If there's one thing that I would like to add on this is that if at all we are planning for a single shot procedure, not for a continuous catheter procedure, then I think so ESPB would be preferable to paravertebral, because the paravertebral would have an effect for about hour, 2 hours, not more than that, whereas ESPB has been seen to have prolonged efficacy. The duration of effect of ESPB is prolonged, something varying between 12 to 24 hours. And if you give an additive along with your local anesthetic, then definitely we can ensure with a single shot analgesia for about 18 to 24 hours.
Dr. Chetna, but then what I would feel is, see, except for what I would say is the post-operative pain relief, where we might be using a single shot thing. But then for most other indications, especially to manage chronic pains like those of rib fractures or a neuropathic pain, I would feel that giving a continuous block gives us a much more leverage, much more pain relief, which lasts for almost, we can take those catheters for almost 5 to 7 days. So what I would see, instead of, I would feel that instead of, because I would find that the catheter placement is quite easily done with this thing, and is not with too many complications. We have kept these catheters for almost a week also with a good amount of pain relief. Though the only this thing is that even with the catheter, the need for local anesthetic is like it has to go to almost like 4 to 5 ml per hour, or like you are giving almost every 4 or 5 hours you have to give almost 20 ml of local anesthetic. You have to repeat almost 5 to 6 hours. So because if we want that wider coverage. So that is the thing. But I would feel is that doing a continuous block is so most of the indications where we are using, as I told you, except for managing acute pain out of surgery. But then for rest all indications, I would strongly think that, and even for surgeries in breast surgeries or other surgeries where the pain is like expected to last for quite few days, I would say that continuous block is much better than even adding additives actually.
Yeah, both of us are on the same opinion, Dr. Pushpinder. I was speaking about post-operative pain. I was not speaking about rib pain or neuropathic pain. So definitely yes, for prolonged duration, for number of days if you want, then definitely catheter has to be there. I was just comparing paravertebral to ESPB in terms of if a single shot is being given a trial.
Thank you. Very nice. We got both the perspectives from acute and chronic pain. So the next question for Dr. Varun is efficacy of therapeutic periarticular and intra-articular SI joint MIPSI same. So Dr. Varun. Please unmute yourself, Dr. Varun.
Hello. Can you hear me?
Yes.
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 Thank
you for the question, Dr. Avnish. I'm just trying to share the screen. So can you see the screen?
No, actually, screen is already being shared by. Yes, now we can see.
Okay, so this is the study for the periarticular intra-articular. So what this says in conclusion that periarticular injection is more effective and easier to perform than intra-articular injection should be tried initially. Another study you can see that comparing both fluoroscopic guided intra-articular and periarticular injections, the both intra-articular and periarticular sacral injection provide statistical immediate and so no significant differences in the degree of pain relief achieved. So in the studies, when we see the evidence, it says that you see both periarticular and intra-articular being efficacious in for the same almost same duration and the intensity. So what I do is I do intra-articular, and sometimes if there is like pain on feel that pain is in the ligaments also on like you do the tenderness test for the PSIS, and then you also check for the gluteal muscles and all, and try to elicit the tenderness deep inside. If you see that and there's more of radiating up also, then I would do a little bit of periarticular injection also while doing intra-articular. So that's how I do it. So I don't know, if you go for periarticular also, you might get almost similar results.
Okay, very nice, Dr. Varun. Now the next question, it is very nice to see that even other specialties are attending our webinar, and it is a dermatologist from Udaipur. They're asking, is there any role of ultrasound guided action for injectables like anesthetic with or without corticosteroid therapy for post-herpetic neuralgia? I feel she is asking for the local injections into the skin, although I don't think it is too much effective, but can we have a perspective from our speakers?
So I think post-herpetic neuralgia is mainly neuropathic pain. Injecting inside the skin might not give the results because you are not targeting the nerve, which is the culprit here. Because virus is infecting and destroying the nerve here. So you need to target the nerve. So better to go for probably some pulse radio frequency or targeting injectables in towards the nerve, like steroids, strong anti-inflammatory drugs, or local anesthetics there. That is better. You can use neurolytics also, alcohol, you can use it. So better target the nerve for PHN.
So you move, so you mean we should be more centrally towards our...
Yes. Also, if you give steroid in the skin, there will be side effects, like there will be scarring and hardness of the skin would be there. It is not advisable to give steroid in the skin superficially.
Anyone else has experience in this? Okay, Dr. Anurag sir, there are many questions about courses in pain medicine, and people are asking
I saw that. So currently, All these courses which we have mentioned here, they are available largely for the MD and ND. But there are private fellowships going on in many places in the country, where other specialties are also being paid for. As ISPC caters to the formally trained physicians in the country. So we consider it as the super specialty branch of anesthesiology, like the neurosurgeries of surgery and other branches, so on and so forth. But there are options. But what we promote that all anesthesiology residents consider them as our future, and if they are interested in the pain medicine. So the one purpose of these seminars, webinars is also to stimulate them and to make them knowledgeable about the pain medicine and the scope of pain medicine in the country and the world, so that they can make conscious career choices in the early part of their careers. I think that's suffices the question.
Very nice. Dr. Pushpinder, there's a question for infusions. What volume you use and how many days do you leave the catheter? And if you add any additive, please mention that.
I was actually thinking about coming to that because I have practices we have quite frequently we have used these infusions. Now it depends what sort of block. Like as I told you, for a rectospinal block, we would like to go at a higher rate, almost 4 to 5 ml per hour. Would be the one. In other blocks, it might be a little less. And nowadays, we have these disposable pumps, and they are available in different. This thing we can get any amount of infusion rate, right from like 2 ml per hour to almost 5 or even more than that. And even they have added at times, even with the disposable pumps, they have added a demand dose thing also. So these are, I would say, sort of like there's a wide variety of such disposable pumps which are available, and they are not that difficult to carry. Also, you can quite easily attach them, and the patient can be mobile using along with those pumps. So definitely, I would say that, and I don't think that skill-wise, doing a single shot block or a continuous nerve block, I would say that I don't think the skill set to be different. If you're doing many of these blocks, if we are doing single shot, we can do it like we can do it as a continuous block. We can direct a catheter into that into the space, the perineal space, and the medicine can go on. And we have retained these catheters for almost like 5 to 7 days easily. We would avoid to keep them more than 7 days, but till 7 days we have kept. So and I haven't seen much complications, except for when these catheters have been for too long there, and mostly they are the complication is in the form of like local infection, which is almost.
एक सेकंड, अरे chat है इसमें, chat है.
And do you use boluses? And is the spread better with boluses, Dr. Pushpinder?
Yeah, boluses very rarely. Like I told you, with the rectospinal block, yes, at times we use these. We have to use these bolus because you need quite a high volume actually. Rest of the blocks, it is only that suppose when these infusions, like suppose patient running a physio or these infusions have been off for some time, or at times we are not using a pump. In that case, we might use a bolus. Otherwise, mostly it's not needed, or only needed for a I would say a breakthrough pain. At that time, we might give a bolus. Otherwise, mostly as a routine, if a continuous this thing is going on. See, what we have to see is, because if a continuous infusion is going on, like a local anesthetic, every hour is getting added, and some amount of previous local anesthetic stays in that place. So if we see over time, it gets accumulated. So most of the time, we would not need these bolus on a regular basis. No, we would not need these bolus. Only like as I told, if the infusion has been stopped for some time, and when we restart it, we give a bolus first and then use it. Otherwise, mostly we would not use bolus, except for like as I told you, rectospinal block where we require quite a high dose. That's why. And compared to additives, I would say I would believe as if like if we can maintain the catheter, it is much more safer than usually adding an additive. Because if you are adding an additive, because people have tried using different additives, but then we do not know. And secondly, we do not know what is happening to the drugs. Because the times there is the change in pH, there is change in everything. So rather than adding additive, why not to give a continuous?
Okay. So, Dr. Varun, is there any role of PRP for sacroiliac joint pain?
Hello. Yes, yes. Thank you for the question, Dr. Avnish. This PRP is quite nicely being used in different interventions for pain and also in other specialties too. Let me share a few studies here. Can you see the screen?
Yes.
Can you see the screen?
Yes, yes,
Yes.
you can.
Yes, we can.
Okay. Okay, so this is one study which is showing that for 4 weeks and then 6 months, they had sustained relief with ultrasound guided PRP injection in the sacroiliac joint, intra-articular injections. And this is another study which is saying that they found good results for 1 year. They found pain relief for 1 year. And this is one study that we published in 2017 in which we compared steroid and platelet plasma in ultrasound guided sacroiliac joint injection. So we also found that platelet plasma had duration of effect was better than steroids for PRP. It remained free. Usually, what we did was we gave PRP and steroid in 2 arms. It was a randomized controlled trial, and at 3 months when we followed up, duration was good for PRP. The efficacy was good for PRP, while it was not that much good for steroids. So that is one thing. But steroids have a very quick effect, like they give effect in 48 hours or probably 72 hours, while PRP takes time. Patients usually get a little more pain initially and then they get relief. So around 1 week to 2 weeks, patient started having pain relief, and it went on till long. I also, in this study, we have not published it, but I followed up at 6 months also. Few of the patients, they had relief with PRP. And very few patients with steroid had relief, but PRP, more of them had relief at 6 months also. So I think PRP is a good technique. There are studies coming in for use of PRP in sacral joint also. So I think you should be doing more of it.
Okay, thank you, Dr. Varun. Dr. Sarita ma'am and Dr. Anurag sir, so we are finished with the questions. So I would hand over the baton to you.
Yes. Before concluding the session, I would like to request our President, Dr. Deepak Thapa, if he wants to give some input regarding these procedures. If he is there.
Thapa sir, are you there? I don't think that he is not.
Then lastly, I would like to conclude the session. So today we have learned about how can we relieve the patient of shoulder joint pain, patients of hip joint pain, and myalgia prosthetica, and other upper back pain. So I hope definitely you will be benefited from these lectures taken by our very learned physicians, and I hope this is very fruitful to you. And lastly, I would like to thank all the speakers, moderators, and our secretary, Dr. Anurag. And thank you. Thank you.
Thank you all of you. And I am really I would like to say a word about the use of ISSP and ISPC supported terminology by most of the speakers in today's webinar. The name nomenclature which ISSP has released is going to take this branch very far, and it is very encouraging to see. And I would like to say a word or a humble suggestion to all my future speakers also that we would prefer if you show your own videos, your own pictures, your own things rather than which are available on the net. So that will make it more trustworthy and useful for the Indian population of the pain physicians to copy and simulate that. So this is just a humble suggestion. I know that it is not possible in every slide, but as much as possible. So I would like to thank all the speakers who have really done very hard work in making the presentations and very useful. Even I could understand a lot of it because as I told earlier, I am not very much proficient with the ultrasound. Rather, I am completely illiterate with the ultrasound. But I could understand a lot of things today. So thank you, Dr. Nishad, Dr. Pushpinder, Dr. Varun Singla, Dr. Akanksha, for your wonderful presentation. Especially Dr. Nishad, I would like to comment upon your presentation. Your videos were really amazing. Perhaps there is a role of machine also in that. You must be using a very high-end machine. So
Thank you, sir. Thank you, sir.
yeah. So I am thankful to Dr. Avnish Khare, who has really done a marvelous job in moderating this webinar, and Dr. Satta Singh ma'am for the coordination and for the initial and as well as the concluding remarks about these webinars. I would just like to add these are the free activities, academic activities on the behalf of Indian Society of Pain Clinicians, the only body which comprises of the formally trained pain physicians in India. And we will keep on doing these activities to stimulate and help our future generations of the residents who may want to take pain medicine as their career option, as well as to the future pain physicians who are working in the field or they are still in the making of the pain medicine. So thank you all. With this, with the permission of my fellow coordinator, Dr. Sarita Singh, I am concluding this session, and we will be back again with another webinar on some very interesting topic for all. Thank you all. Thank you all the participants from the different part of world and India. And we thank you all and keep safe, keep healthy, and take care. Bye. Bye for
Thank you, madam, for giving opportunity.
Thank you. Thank you.